Hello everyone and welcome to another segment of SDOH Field Guide presented by Advocate Advisors. I'm Michael Sattler. The social determinants of health are being discussed everywhere right now, but there are a lot of people who still have questions about what that means and what to do about it. The Field Guide is a starting point for people to get quickly up to speed on social determinants of health. If you have a question about SDOH to which you'd like to see a no-nonsense answer on camera, please tweet it to @SDOH Field Guide. Now, in past segments, we looked at the major components of social intervention programs. Today, we're going to focus on the first step, identification. Now, this is essentially an answer to the question, on whose behalf are we intervening? After all, you got to have somebody to serve, and they have to come from somewhere. Now, we've seen three broad answers, or vectors, to the question of how do people get into a program. The first is self-identification. These are people who have held up their hand and acknowledged that they have a social need that needs to be addressed. Now, some of the programs we've seen run in-person clinics, and individuals step up to a desk or a kiosk or an advocate of some kind to explain who they are and what they might need. Some programs have a website where the general public can interact with the search. Many 211 programs like Connecticut 211 and Hartford do a great job with this. Anyone can come to a website and search for programs that offer services they need and set up accounts for themselves if they wish to later. Some programs have staff in the field. One program we've seen, concentrating on people experiencing homelessness, would dispatch staffers with iPads or iPhones into the field to interview and offer engagement to the people that they came across. The second way to identify people for social intervention programs are those who have been flagged by others, by experts. Now, the first vector is what's often referred to as social prescribing. Now, this is where a clinician identifies a social need in a healthcare setting and prescribes a social intervention to deal with it. It's important to recognize that clinicians are generally not specialists in social needs. It's like if a general practitioner identified a skin condition that looks suspicious. They'd indicate their suspicions to the dermatologist, but then rely on the dermatologist's expertise from that point on. With social needs, it's the same thing. Let the social specialists handle the details. The next expert referral category is what's sometimes called a sideways referral. Now, a sideways referral occurs when an organization caring for a recipient in a community identifies a need they can't support and refers that care recipient to another organization who might be better able to meet their needs. This occurs a lot, for example, when food banks identify someone that might have a housing or a transportation risk, for example. The food bank can't help with housing, but another organization in their community may be able to. The third way to get folks into these social interventions programs is through some kind of analysis or algorithm associated with external data that flags them for enrollment. Public health programs and analytics teams are getting very good at using data to uncover hotspots of individuals who may have a social need and then flagging them for further action. For example, mapping the geographic locations of opioid emergencies could point to neighborhoods where residents may be at increased risk of substance abuse. Often the data is combined with other factors like emergency room visits or patterns of billing claims or clinical diagnoses, which can then highlight people who would otherwise not voluntarily be engaged in an intervention program. Another category are groups of individuals flagged by accountable care or managed care organizations and or enrolled in a state-based Medicare or Medicaid program. Long-term services and support and whole-person care programs can often fit into this category. Now, a few things to mention as we wrap up. First, healthcare data is a protected kind of data in the United States and most other countries, and strict rules exist for what data can be stored and shared. The necessity of observing good personalized health information data hygiene, contractual protections among participants, and consents from the individuals themselves is fundamental in these kinds of intervention programs. We can dig into all of that in more detail later. And finally, even though these intervention programs have been developed from the perspective of the social determinants of health, nothing about where patients come from needs to be limited to hospitals or doctors or clinics. There's no reason why a public safety organization like a police department or a COVID-19 contact tracing initiative couldn't plug into a social intervention program on their own. In fact, when you step back and think about it, if we're going to be putting networks of social specialists together, why wouldn't we use the same networks for a variety of different purposes? Community collaboration is community collaboration, whether the care recipient started with a doctor visit, a contact trace, or a 911 call. And that should do it for this segment. Thanks very much for watching. If you have a question you'd like answered on camera, tweet it to @SDOH Field Guide. Once again, I'm Michael Sattler from Advocate Advisors, and this has been the Field Guide. Thanks very much.